Welcome back to the deep dive. Today, we are strapping in for, well, an intensely focused session. This is designed not just for casual learning, but really for high-stakes clinical decision-making. We're entering the world of daycare, or, as it's often called, ambulatory surgery and anesthesia.
Indeed. And we're going to be looking at this landscape through the eyes of two, I think, very crucial figures. The MD examiner, who demands that conceptual clarity, and then the clinician, who demands absolute patient safety.
Right.
So this isn't some theoretical exercise. This is all about optimizing pathways to ensure same-day discharge. And that's a practice that now accounts for, something like 80% of elective surgeries in many healthcare systems.
80%, that number. I mean, that statistic alone just highlights the sheer critical importance of mastering this area.
It's the default now.
Our stack of sources is rich. It's full of clinical guidelines, pharmacology specifics, and, those crucial discharge criteria. It's really a roadmap to handling complexity with maximum efficiency.
And our mission today is, I'd say, twofold. First, we need to distill the core, the high-yield principles that separate successful, safe practice from the major clinical pitfalls.
The kind of thing that comes up in exams.
Exactly. The kind of knowledge that scores highly in a 10 or 20 mark theory question or, saves you in a high-pressure viva. Second, and I think this is more important, we need to make sure you can apply these principles immediately in the operating theater, the recovery room, and right up to the point the patient gets in the car.
And the central tension here, I think the core paradox that defines ambulatory care today, is balancing that increasing patient complexity. We're talking older, sicker patients with that absolute demand for a reduced length of stay.
Yes.
We're pushing the boundaries of what is possible safely and efficiently every single day.
Precisely. And the central thesis that you have to hold on to is this. Anesthetic choices directly, and I mean measurably, determine discharge readiness. They influence recovery kinetics down to the minute.
Yeah.
But, and this is the key, successful outcomes have to begin long before the first drug is drawn.
It's all in the prep.
It starts and it ultimately ends with meticulous patient selection and preparation. So let's unpack the landscape first.
Let's start with definitions. If you're running a day case unit, you need a precise professional yardstick for what actually qualifies as daycare surgery, especially for documentation and, medical legal purposes. What's the defining characteristic we should be teaching?
The defining characteristic is, in a word, the intention. The internationally accepted definition, and this is the one often cited from the International Association for Ambulatory Surgery, or IAAS.
Yeah.
That's the yardstick.
Okay, so what is it?
A surgical day case is officially defined as a patient who is admitted for investigation or operation on a planned non-resident basis, and who nonetheless requires facilities for recovery. And it adds that the procedure shouldn't require an overnight stay.
That emphasis on planned non-resident basis feels key. Why is that upfront intention, right from the pre-assessment phase, so important? Why is it a non-negotiable safety feature?
Because the entire system has to be geared for it, for rapid turnaround and safe post-operative care at home. I mean, think about it. If you have a planned inpatient procedure that just happens to finish early and you think, oh, let's send them home.
They haven't been prepped for it.
Exactly. They haven't gone through the right filters.
Yeah.
They lack the tailored preoperative counseling, the designated escort arrangement, the right prescription for analgesia at home, and, the structured follow-up. The safety's in the planning, not the spontaneity.
This concept certainly hasn't stayed static. I mean, looking back, the early origins of day surgery in the 1910s, 20s, they were incredibly restrictive. How has this field evolved to handle the sheer volume and complexity we see today? That 80% number is just staggering.
Historically, yes. It was incredibly narrow. It was reserved only for the absolute healthiest patients, your ASA, undergoing very minor operations.
Right, hernia repairs and the like.
Almost exclusively.
Yeah.
But we've undergone a philosophical change. We've challenged what used to be these conservative, often outdated practices that just mandated unnecessary overnight stays for no good reason. And this evolution is driven by two main technological leaps.
Okay.
First, the massive rise of minimally invasive surgical techniques that dramatically reduces tissue trauma, pain, blood loss. And second, the continuous pharmacological refinement of our drugs, these ultra-short-acting anesthetic and analgesic agents.
So the recovery clock just starts ticking faster.
Faster and with fewer side effects.
Yeah.
It's a game changer.
The expansion of day surgery must offer some pretty significant benefits across the entire healthcare spectrum. Otherwise, the system just wouldn't have adopted it so widely. For our listener who's, looking for those high-scoring conceptual points, What's the triple advantage of daycare surgery?
Right. So we categorize the advantages into three critical areas. It's about satisfying patients, hospitals, and budgets. First, the patient advantage.
Okay.
This is deeply human. They benefit from the comfort, the convenience of recovering in their own home. It promotes a better mood, reduces anxiety, but there's a more profound clinical benefit, especially for older patients.
What's that?
There's emerging evidence of reduced incidence of postoperative cognitive dysfunction, or POCD, compared to the exact same procedures done on an inpatient basis.
Wait, let's stop on that POCD point. That's fascinating. We often focus purely on the pharmacokinetics of the anesthetic, but you're saying that the psychological security and just the familiar stimuli of being at home is actually a measurable therapeutic intervention against cognitive decline.
It absolutely is. That completely reframes the benefit for older patients.
It really does.
The theory is that the unfamiliar, often disruptive environment of a hospital ward, the sleep disturbance, the noise, the activity, it all contributes significantly to POCD in susceptible individuals.
Yeah.
Ambulatory care just avoids that trauma.
Excellent. Now let's talk business. What about the system benefits and the often overlooked economic advantage?
So second, the hospital and system advantage. This is all about efficiency and capacity. Daycare significantly reduces the chronic dependence on scarce inpatient beds. It offers greater scheduling flexibility, and crucially, it shortens surgical waiting lists, which is a major quality and, frankly, political metric.
And the money.
Third, there is the undeniable economic advantage. Ambulatory surgery results in lower overall procedural costs. But here's the high-yield insight into why the system is so motivated. If a patient requires an unplanned overnight admission, which is the primary failure metric, the facility often has to bear that extra cost. Many payment models pay a fixed rate for the procedure, whether the patient stays 4 hours or 24.
So there's a huge financial incentive to get it right.
A tremendous financial incentive to ruthlessly optimize the pathway and minimize those unanticipated admissions. It drives better clinical behavior.
That economic pressure ties directly into our next section then. We heard the maxim. Poor patient selection is the single greatest cause of financial loss and patient dissatisfaction in this field.
That is the core teaching rule. Selection criteria are arguably, I'd say they're more important than the drugs you choose. Poor selection bypasses all your carefully calibrated pharmacology and leads directly to an unplanned admission. If you're an examiner, this is where you differentiate competent candidates from real experts.
In the past, selection was easy. If you had any significant comorbidity, you were just out. What's the modern pragmatic approach, particularly concerning the ASA physical status classifications?
The modern approach is to reject arbitrary limits. Limits based only on ASA class or age. The ideal candidates, sure, there's still ASAI, which is perfectly healthy, and ASA2, mild systemic disease. However, the crucial evolution is that ASA3 patients are now commonly accepted.
That's a major shift. What constitutes an acceptable ASA3 patient?
Okay, so this includes patients with stable, optimally managed chronic diseases, we're talking about controlled conditions, stable hypertension on medication, well-controlled type 2 diabetes where their HbA1c targets are met, or stable coronary artery disease, no active angina, they've been cleared post-MI.
The key phrase there is optimally treated.
That's it, optimally treated before the elective procedure.
So if an examiner asked you, can you discharge an ASA3 patient, the answer is a qualified but emphatic yes.
Precisely. The one-liner for your exam is, arbitrary limits based on age or BMI should not automatically exclude a patient. Suitability must be based on a comprehensive assessment of their overall health, their current functional status, and a risk-benefit analysis. The caveat, of course, is if their disease is not optimally controlled.
Like a blood pressure of 180 over 110.
Exactly, or an HbA1c of 10%. They have to be delayed and optimized first. You don't just push them through.
Let's dive into some specific medical conditions that mandate extra scrutiny. Let's start with obstructive sleep apnea, OSA. This feels like a massive concern for post-op respiratory complications.
Oh, it's paramount. These patients are highly sensitive to sedating medications, and that leads to an increased risk of prolonged airway obstruction, desaturation, and apnea after the surgery, particularly after you've given them opioids.
What are the clear red flags that would force an OSA patient into a mandated overnight inpatient stay? No questions asked.
You have to mandate an inpatient setting if the patient has severe documented OSA, say, an AHI over 30, and they're undergoing a high-risk procedure that's going to require high doses of postoperative opioids.
Like a painful orthopedic surgery.
A perfect example. Or, and this is crucial, if the patient normally uses a CPAP machine, but is unable or unwilling to use it in the postoperative period at home. Compliance here is a clinical safety metric.
So the anesthetic strategy itself becomes the mitigation strategy. How do we ensure a safe discharge for the acceptable OSA patient?
The entire anesthetic plan has to be built around opioid-sparing multimodal analgesia. We minimize or completely eliminate respiratory depressants. Furthermore, preoperative optimization is key.
How so?
We encourage or even mandate that the patient uses their CPAP preoperatively. There's good evidence suggesting this may actually reduce the incidence of postoperative cardiac complications, and we have to counsel them heavily on positioning non-supine, during that first critical 24 hours at home.
Moving to the other end of the age spectrum, how do we handle geriatric patients? Age alone is not an exclusionary criterion, you said, but what criteria are?
Age alone is absolutely not exclusionary. In fact, as we noted with POCD, a rapid return home can actually be beneficial for them. However, we have to assess for factors that are associated with poor surgical and recovery outcomes, and the main one is frailty.
How do you objectively screen for frailty in a busy pre-assessment clinic? It sounds subjective.
We use screening tools that look at functional status, specifically activities of daily living ADL and instrumental activities of daily living IADL scales. These help identify patients who might be able to handle the surgery itself, but whose recovery is jeopardized by poor baseline function.
Or they just can't cope with the sudden decrease in mobility post-op.
Exactly. And identifying these high-risk, frail patients early allows us to activate essential services like early physical therapy referrals or getting social work involved to ensure that safety net is in place before they're discharged.
That's a proactive approach. So the focus shifts from just organ function to overall functional status. And I imagine polypharmacy must be a constant headache.
It is. It's ubiquitous as this age group. The goal in the PAP, the pre-assessment clinic, is to review the drug list, not necessarily stop everything, but identify high-risk medications like excess sedatives or blood thinners that need careful perioperative management. The functional status of all their organ systems, cognitive, renal, cardiovascular, that's what really matters.
Now let's consider the non-clinical criteria. The social factors that, despite a perfect medical chart, can just derail a patient's discharge plan and expose the facility to medical legal risk.
This is where non-clinical safety is absolutely paramount. First, the Escort requirement. This is mandatory for all patients receiving general anesthesia or procedural sedation. It is a non-negotiable medical legal checkpoint.
And that means a responsible adult takes them home.
And ideally is available and responsive to the patient's needs for the critical next 24 hours.
Why the 24-hour recommendation? What is the specific risk we're trying to mitigate in that window?
We're mitigating the residual effects of all the drugs we've given them, the sedatives, opioids, volatile agents. They can all impair judgment, coordination, the ability to operate machinery or make complex decisions. You need a safety monitor.
Okay. Well,
second, the patient must demonstrate adequate home support and compliance. They have to be able to understand and follow all the written discharge instructions we give them. Third, we address distance and accessibility.
how do you define reasonable traveling distance? That must vary wildly between, say, a city and a rural area.
It's not a fixed mileage, it's a clinical judgment call. It means the patient must be able to reach emergency care or their designated surgical facility within a time frame that's medically safe if a complication arises.
Like unexpected bleeding or severe pain.
Precisely. And access to a functioning telephone for summoning assistance is the bare minimum technological requirement, especially if they're traveling long distances or live in a remote area. The system must have a designated 24-hour emergency contact number established and given to them.
Right. Once the patient is deemed suitable, we turn to the procedure. We establish that the old time-based limits, 60 or 90 minutes, are obsolete. The determinant is now surgical trauma. Can you give us a concrete example of this shift?
Absolutely. The determinant now is the extent of surgical trauma and the expected post-operative consequences.
Yeah.
So a 3-hour laparoscopic cholecystectomy or an arthroscopy, while long, is minimally traumatic.
Very little blood loss, manageable pain.
Exactly. The pain can be managed effectively with a regional block and oral analgesics. These are routinely successful day cases. Conversely, a brief but bloody dental extraction that requires complex airway management and multiple opioids, or a complex open hernia repair with large tissue dissection might be less suitable, even if it's shorter.
So what are the lines we absolutely will not cross? What are the hard contraindications?
Procedures must not be anticipated to involve significant blood loss. That usually means requiring transfusion or large fluid replacement. No large perioperative fluid shifts, and they can't require complex, specialized postoperative care like invasive monitoring.
And the classic textbook contraindication.
The classic contraindication for ambulatory surgery is any procedure involving raised intracranial tension, ICT, or intracranial space-occupying lesions. The risks of acute deterioration are just too high to manage at home. Major abdominal or thoracic procedures are also generally excluded.
This systematic approach needs a dedicated gateway, the Focused Preoperative Assessment Clinic, or PAC. What are the modern goals of this evaluation, knowing that the default assumption is now ambulatory care?
The role of the PASIC is often misunderstood. It's not primarily an exclusion committee. It's an engine for evaluation and optimization. Our goal is to identify and resolve any barriers to that early discharge.
So you can think of it like a flowchart.
Exactly. A flowchart with 3 key questions. 1, is the patient fit, meaning ASA I2, or as stable, optimally controlled. 3. 2, is the procedure suitable based on surgical trauma? And 3, what needs to be done to ensure same-day discharge?
And that last question is what drives the optimization?
It is. It drives delaying the case for blood pressure control or initiating CPAP or arranging home supports. It reframes the PECIs as an optimization lab.
Okay, now let's tackle investigations. The pressure to order routine labs is immense, but often they're just unnecessary. What are the minimum necessary investigations for healthy patients?
You're right. Routine lab testing is generally not required for healthy asymptomatic patients, your ASA, AC, AAA2. Ordering a full blood count or electrolytes on everyone is low-value care. It can actually generate false positives that delay the case for no good reason.
So it has to be targeted.
Testing must be based strictly on the patient's history and physical examination. For instance, a hemoglobin or hematocrit is appropriate for all females of childbearing age due to menstrual loss, but not routinely for, say, a healthy 60-year-old man having a cataract procedure.
And ECGs, what are the guidelines there?
ECGs are typically obtained based on age thresholds and comorbidities. The common guidelines suggest for men over 40 and women over 50, or for any patient with known significant cardiovascular, pulmonary, or renal disease, regardless of their age. Clinical judgment should guide testing, not boilerplate, non-specific order sets.
Finally, let's address the most common fundamental barrier to any elective surgery. Fasting. Can you detail the specific ASA fasting guidelines? This is absolutely essential high-yield content.
These specifics are non-negotiable for safety and for your exams. We adhere strictly to the American Society of Anesthesiologists, the ASA guidelines. They balance safety, so the risk of aspiration, against patient comfort.
So what are they?
Okay. Clear fluids, a minimum of 2 hours. This includes water, clear tea, black coffee, fruit juices without pulp. Small volumes are okay up to 2 hours before. Breast milk for infants is 4 hours. Non-human milk, infant formula, or a light meal like toast or a cracker, 6 hours.
And the big one?
Fried or fatty foods, or meat, 8 or more hours. Fats significantly delay gastric emptying.
Why are we so strict about adhering to the minimum times and avoiding prolonged fasting? Why not just say nothing after midnight?
Because excessive fasting is just detrimental.
Yeah.
It's bad for the patient experience, and it can impair recovery.
Right.
About half of ambulatory patients complain bitterly of hunger, thirst, or headache, which significantly worsens their preoperative anxiety.
And there's a clinical risk, too.
Yes, more clinically concerning, excessive fasting risks hypoglycemia, especially in children and thin young women, and it can lead to dehydration. The modern practice is to be highly disciplined about fasting, no more and no less than is necessary.
The ultimate goal of the anesthetic choice is to facilitate fast-track recovery and early discharge. This means choosing, professional athlete drugs, rapid onset, perfect performance, immediate exit, and minimal lingering side effects. Let's look at induction for general anesthesia.
For induction, Propofol is absolutely the gold standard for modern practice. Its benefits are manifold: rapid onset, rapid redistribution, and a recovery profile that, crucially, includes antiemetic properties. That is a major advantage in a setting where PONV, or nausea and vomiting, is the enemy.
And older drugs like silopentone.
They've largely been superseded because of their slower recovery profile and a much higher incidence of post-induction nausea.
For maintenance, the choice of volatile agents seems highly debated, with low blood gas solubility being the key feature for rapid recovery. Can you clearly compare sevoflurane and desflurane for our listener?
Right. The key to rapid recovery is minimizing the time it takes for the agent to wash out of the blood and body tissues. Sevoflurane has low solubility and it's non-irritating, which makes it ideal for an inhalation induction, especially in needle-phobic adults or children. It provides a faster awakening than older agents.
But then there's Desflurane.
Then there's Desflurane. It's the fastest drug in our toolbox.
And why is it the fastest? What's the science?
It has the lowest blood-gas partition coefficient, a remarkable 0.42. This just ensures the fastest washout and elimination from the system. Now, for brief procedures, say under an hour, the recovery time difference between Savo and Delos may be negligible. But
For longer cases.
Desflurane's unique speed becomes significantly beneficial and clinically appreciable for longer procedures, those lasting 2 hours or more. It translates directly to the fastest possible awakening.
But there's a trade-off, isn't there? If we're using Desflurane for that fast washout on a 3-hour case, we know it's irritating to the airway. Are we not just trading a fast wake-up for a potentially higher risk of laryngospasm or a bad cough that itself delays discharge? Where's the practical break-even point?
That is precisely the clinical friction point. Desflurane is irritating, so you would never use it for an inhalation induction, and it can cause airway reflexes or coughing on emergence. The break-even point is typically procedural length and the patient's own airway risk. If the patient has a reactive airway, a smoker, mild asthma sevoflurane is generally the safer choice for a smoother, albeit potentially a minute or two slower, recovery.
So you weigh the speed against the risk of airway complications.
You have to. An airway complication will delay discharge far longer than a slightly slower wake-up.
What about the common adjunct nitrous oxide? Its routine use has clearly declined in daycare.
It has, substantially, because the risks often outweigh the benefits in an ambulatory setting. While it has rapid pharmacokinetics, its major drawbacks are twofold. One, it causes bowel distension, which is terrible for the laparoscopic surgical view and causes post-op discomfort.
And two,
it is significantly immunogenic. It increases the risk of PONV. Furthermore, it's explicitly contraindicated in patients with severe pulmonary hypertension. We generally restrict its use to very specific scenarios where rapid onset is paramount and the procedure is extremely short.
in terms of airway management, what's preferred to maintain that minimal morbidity profile?
We prioritize reducing any minor morbidity that could delay discharge. So, alternatives to endotracheal intubation are preferred. Airway maintenance using a laryngeal mask airway or LMA or even a face mask is generally favored over the ETT.
To avoid sore throats.
To reduce minor complaints like sore throat, hoarseness, and associated coughing spasms, all of which hinder a smooth phase 1 recovery. And when we do need muscle relaxation, only short-acting agents like cisatricurium, vecuronium, or rocuronium should be used for short cases, ensuring reversal is complete.
Let's shift to regional anesthesia, RA, and monitored anesthesia care, or MA. RA feels like a crucial tool for fast-track surgery.
Regional anesthesia is the powerhouse of multimodal analgesia in daycare. It offers effective, targeted pain control that dramatically minimizes or even eliminates the opioid requirement, and that directly leads to a faster, safer discharge.
If we use spinal anesthesia for, say, a knee arthroscopy or a perineal procedure, how do we prevent the motor or sympathetic block from delaying the patient's ability to walk and void?
The key is using low-dose techniques, often combined with a short-acting opioid for the surgical effect, or ideally using very short-acting local anesthetics. This is a really high-yield area for exams.
The agents are we talking about?
Agents like prilocaine and mepivacaine are favored because they have significantly shorter durations compared to the long-acting bupivacaine. This prevents that prolonged motor or sympathetic block that keeps people in recovery.
And what about chloroprocaine? We're seeing a bit of a resurgence of that agent.
Chloroprocaine is a fantastic tool for the true fast-track spinal. It's an ester, which means it's metabolized incredibly rapidly by plasma esterases. This makes it perfect for a spinal where you need duration for the procedure, but you want immediate clearance afterward without that lingering worry of motor block.
Finally, monitored anesthesia care, MIC. It sounds like minimal intervention, but the safety guidelines demand maximum vigilance.
They do. MAC is often used for procedures like cataract surgery or short endoscopies. However, and I have to stress this clinical warning, the term MAC should be viewed as standing for maximum anesthesia caution, not minimal anesthesiology care.
Why the strong warning?
It's critical to understand that MAC involves continuous monitoring and the potential for a patient to slip into deep sedation, requiring airway intervention. Therefore, MAC is no safer than general anesthesia in terms of the vigilance required. It demands the exact same standards of personnel, full physiological monitoring, and immediate access to resuscitative equipment as any GA case. Never treat MAC lightly.
We've established the specific agents. Now we need to synthesize them into that MD-level management philosophy. What are the primary pharmacologic pillars that underpin successful daycare anesthesia and fast-track recovery?
The philosophy is really built on three pillars. First, selecting drugs with a short action and rapid profile. We favor agents that are rapidly redistributed or those that are quickly and actively cleared from the body. This leads to what we call a context-sensitive half-time that is short, even after prolonged infusion.
Can you elaborate on that concept of context-sensitive half-time and how something like Propofol TIVA fits in?
Certainly. Context-sensitive half-time measures how quickly the plasma concentration of a drug drops by 50% after you stop a prolonged infusion. Older drugs, like midazolam or fentanyl, they build up in body tissues, so their clearance time gets progressively longer the longer the case goes on.
But Propofol is different.
Propofol, however, maintains a relatively stable, short context-sensitive half-time because its clearance is high and its distribution is rapid. Propofol TIVA maintenance is therefore excellent for predictability.
And why is TIVA often preferred over volatile maintenance, even if you said Desflurane is technically faster?
This leads us to the second pillar.
Yeah.
PONV, TIVA, using propofol, is significantly less immunogenic than volatile agents. Although modern volatile agents like sevoflurane are better than older ones, they are still associated with a higher risk of PONV.
Why is that?
Because volatile agents are metabolized to a small degree, and these metabolites, or the agents themselves, act as central nervous system irritants, increasing the likelihood of nausea. TIVA just avoids this entire issue.
So TIVA is the default for high-risk PONV patients. That brings us to the third, and perhaps the most critical pillar, multimodal analgesia, MMA.
MMA is non-negotiable. It is the absolute cornerstone of pain management in daycare. This involves combining agents that work via different mechanisms, regional blocks, non-opioids like acetaminophen and NSAIDs, and often adjuncts like gabapentinoids or alpha-2 agonists.
What's the clinical payoff for all that complexity? It sounds like a lot to manage.
The clinical payoff is dramatically reduced opioid usage. Opioids are the single greatest enemy of rapid discharge. They cause respiratory depression, sedation, dizziness, and overwhelmingly, PONV. If we can drop the opioid requirement by 50% or more using MMA, we significantly lower the likelihood of delayed discharge and unplanned admission.
So mastering MMA is mastering daycare recovery.
It really is. They're synonymous.
Speaking of PONV, what is the modern approach to prophylaxis? Is it for everyone?
PONV prophylaxis is a mandatory checklist item. Every single patient must be risk assessed using a validated score, like the Apfel score. If a patient has 2 or more risk factors, female gender, non-smoker, a history of motion sickness or PONV, or planned opioid use, they must receive prophylaxis.
And for high-risk procedures?
For high-risk procedures, laparoscopic, strabismus, or gynecological combination therapy is required. Often a 5-HT3 antagonist like ondansetron combined with a steroid like dexamethasone. And the clinical insight is that timing matters. Giving these drugs just before incision provides maximum effect through that critical perioperative window.
Moving to intraoperative management beyond the drugs, what are the key non-pharmacologic essentials for rapid recovery?
We emphasize 3 non-pharmacological pillars: fluid therapy, temperature control, and opioid minimization as an action point.
Let's discuss fluid therapy. In longer cases, we often worry about third spacing, but we also want adequate perfusion. What's the standard approach?
Generally, a restrictive fluid management strategy is preferred, but modern practice leans towards goal-directed fluid therapy. In the context of healthy day cases, though, restrictive really just means avoiding unnecessary overbagging of the fluids.
Because that causes its own problems.
Right. It can contribute to peripheral edema, postoperative swelling, and just that vague feeling of discomfort that hinders ambulation and recovery. We aim to replace the deficit and third space losses accurately, not flood the system.
And temperature control. Why is normothermia so critical for discharge speed?
Maintaining normothermia is absolutely essential. Even mild hypothermia delays drug metabolism. It increases the risk of coagulation issues, increases infection risk, and it causes shivering. Shivering significantly increases metabolic demand and oxygen consumption.
And it's just miserable for the patient.
It's profoundly uncomfortable and actively prevents a patient from meeting recovery criteria. We have to maintain core temperature using warming blankets, fluid warmers, and attention to the operating room temperature.
So if we look at the entire intraoperative phase, what is the one metric that really dictates phase 1 success?
It is the level of residual sedation and pain. By achieving strict opioid minimization through these multimodal approaches, we prevent postoperative respiratory depression, and we facilitate the possibility of recovery room bypass, which we call fast-tracking.
The journey isn't over until the patient is safely home. Let's walk through the recovery room progression, starting with the criteria for moving from Phase 1, the PCU, to Phase 2, the recovery lounge.
Phase 1 is that high-stakes period immediately following emergence. The criteria for progression to Phase 2 are all about stabilization of major physiological systems. The patient must be awake and oriented, normothermic, maintaining their own patent airway and adequate ventilation, showing cardiovascular stability, and crucially, pain and PONV must be initially stabilized and adequately treated.
Relying purely on subjective judgment here seems insufficient. This is where the scoring systems provide the objective data that an examiner wants to see. What's the standard system used for this transition?
The gold standard is the modified Aldrete scoring system. This system assigns a maximum of 2 points across 5 physiological categories: respiration, O2 saturation, consciousness, circulation, and activity. A score of 9 or 10 indicates they're ready for transfer to Phase 2.
Can you give an example?
Sure. The patient must be able to move all 4 extremities voluntarily, that's 2 points for activity, and have an SpO2 greater than 92% on room air, which is 2 points for O2 saturation. Objective scoring like this eliminates subjective bias.
The fastest path is the fast-tracking concept. When can a patient skip Phase 1 entirely?
Fast-tracking is the ideal outcome, bypassing Phase 1 PGQ entirely and going directly to Phase 2. Eligibility is strict. It requires the patient to meet the Phase 1 discharge criteria immediately upon exiting the operating room.
And that's only achievable with the really short-acting agents.
Only consistently achievable when you're using those ultra-short-acting agents, Desflurane, Propofol, TIVA, romifentanil, and when the surgery involves minimal trauma, where you've got high-quality regional analgesia on board. If the patient coughs, is mildly hypotensive, or needs suctioning, they fail the fast-track criteria.
Okay, so once they're stabilized in Phase 2, they're being monitored for final discharge. This is the ultimate medico-legal and clinical responsibility. Can you detail the critical criteria that constitute the gold standard for home readiness, maybe using examples from systems like PASS?
Discharge is a physician's responsibility, and it has to be based on documented criteria. The PSS, the post-kinesthetic discharge scoring system, or similar checklists are essential.
What's on the list?
Okay, first, mental status. Alert and oriented to time and place, back to their baseline. Second, vital signs. Stable, typically defined as being within 20% of their pre-procedure value for at least 30 minutes. Third, pain and nausea. Pain controlled to a tolerable level, maybe 4 out of 10 or less, by oral analgesia, and any nausea must be mild and fully controlled.
And surgical factors.
Minimal, unexpected surgical bleeding, so no further dressings or active monitoring needed. Mobility, able to walk without dizziness. And finally, information and support. Discharge instructions have been given, and that responsible adult escort is present and ready.
Let's hit the crucial examiner trap regarding voiding and oral intake. Many experienced clinicians, myself included, learned that the patient must urinate and drink before going home. What is the modern evidence-based stance on that?
This is a critical insight into modern ambulatory practice, and it's all about overcoming historical anxiety. Voiding urine and retaining clear fluids are no longer considered essential routine prerequisites for discharge for all ambulatory patients.
Why the change? That feels like a big shift.
We realize we're unnecessarily delaying safe discharge based on a metric that simply doesn't predict risk for the vast majority of patients. Holding a patient for 4 hours just to see them void increases facility costs and reduces patient satisfaction, particularly after procedures where urinary retention isn't a major expected complication.
So it's procedure dependent.
Exactly. For high-risk procedures, urological stuff, spinal anesthesia with long-acting agents retention is still a concern, and fluid intake output is tracked on the PASS. But for routine general surgery or orthopedic cases, the ability to walk and adequate pain control take precedence. Delayed voiding management should be planned for, not waited for.
That's a crucial differentiator. Finally, what are the specific complications that most frequently lead to delayed discharge or worse, unplanned readmission?
The metrics are clear across all major centers. The 2 most significant causes of delayed discharge and unplanned overnight admission are, in order, postoperative pain and postoperative nausea and vomiting, PONV. If you control those 2, your admission rate will plummet.
And others.
Other causes include urinary retention, especially after a regional block or urological procedures, and unexpected surgical bleeding.
Ambulatory care is comprehensive, extending across the lifespan. Let's consider special populations, starting with pediatric considerations. What are the key airway and emergence differences in children?
In children, the anesthetic goals are the same, but the pharmacodynamics are different. Sevoflurane is the preferred agent for inhalation induction because of its non-irritating, non-pungent odor. It allows for a smooth mask induction, avoiding a stressful needle stick for the child.
And what specific recovery issue is nearly unique to children, particularly with these rapid-acting agents?
Emergence delirium. Rapid emergence from low-solubility agents like sevoflurane is associated with a high incidence of agitation, inconsolability, and thrashing in children. It can last 10–20 minutes and is very distressing.
How do you manage that?
Mitigation strategies are essential. They often involve prophylactic use of small doses of adjuncts like fentanyl, maybe 1 microgram per kilo, low-dose propofol, ketamine, or an alpha-2 agonist like dexmedetomidine. They smooth the awakening process without significantly prolonging discharge time.
What about pediatric obstructive sleep apnea, for example, a child undergoing a tonsillectomy?
This is a classic exam contraindication and a major safety risk. Children with moderate to severe OSA, especially when undergoing tonsillectomy, have significantly higher incidences of perioperative pulmonary complications.
Like desaturation and obstruction.
Exactly. These children are not suitable candidates for daycare surgery. They require postoperative monitoring in a high-dependency unit, or HDU, or even an ICU setting due to the risk of life-threatening events.
Shifting to systemic safety, the entire enterprise hinges on continuous improvement. What are the essential quality assurance and safety metrics that everyday care unit must be auditing?
Audit is absolutely essential for maintaining safety accreditation and improving efficiency. We focus on critical negative outcomes. The unplanned overnight admission rate, the delayed discharge rate, for instance, staying beyond 4 hours post-procedure, and readmission rates, especially within 24 hours and 28 days. These metrics are a direct reflection of your patient selection and procedural precision.
We discussed earlier that patient satisfaction is also a core metric. How does that subjective data inform clinical quality?
It connects the technical performance to the patient's lived experience. Studies consistently show that high satisfaction correlates strongly with efficient and friendly care. And here is a profound clinical insight that ties to our later closing thought.
Okay.
The patient's perception of the friendliness and clarity of the OR and KCU staff communication is often cited as a top determinant of satisfaction, sometimes even outweighing their subjective pain score. This means empathy is a safety metric.
That makes the human element integral to the checklist. Finally, let's cover the crucial post-discharge instructions, that final medical-legal checklist item.
Written instructions are mandatory. They have to be explicit, detailing diet, activity restrictions, when they can drive or return to work, and a very clear medication schedule for analgesia. And non-negotiably, the facility must provide a clear, dedicated 24-hour telephone number for emergency contact.
Why is that guaranteed 24-hour contact considered a proactive safety feature rather than just a convenience?
Because the ambulatory patient is self-caring and mobilizing early. Symptoms of a minor surgical complication like unexpected pain or bleeding are often noticed and reported sooner than if they were just passively recovering in an inpatient bed. Providing clear, immediate access to clinical advice allows the team to triage effectively.
So you can bring them back to the facility instead of them ending up in a busy ER.
Exactly. It increases overall safety and reduces the severity of potential complications. It's a proactive safety net.
Okay, let's wrap this up with a high-speed review, synthesizing these high-yield concepts, the kind of rapid recall you need under pressure. Let's start with a high-scoring comparison table. GA versus regional anesthesia in daycare. What are the crucial trade-offs?
The trade-offs are significant. General anesthesia offers greater control over the airway, which some surgeons prefer, but it carries that inherent risk of higher PONV rates and prolonged residual sedation, unless you use TIVA.
And regional.
Regional anesthesia offers superior, prolonged post-operative analgesia and avoids GA side effects. But it carries its own specific risks of delayed discharge if long-acting local agents like bupivacaine are mistakenly used, or if the block causes temporary side effects like urinary retention.
And a quick summary comparison of inhalational agent selection, the speed demons.
Low solubility is the defining factor. Desflurane. Fastest recovery, especially for longer cases, but it's irritating, needs special vaporizers, and is costly. Sevoflurane. Smooth, non-irritating induction, fast and comparable recovery for shorter cases, making it the most commonly used agent overall. Isoflurane. Slower washout, generally avoided in fast-track settings due to prolonged emergence times.
Time for some classic examiner traps and crisp one-liners. What is the single most common reason for a delayed discharge?
Pain, closely followed by PONV. If you're managing in a day unit, those two are your targets for quality improvement.
Can you discharge an ASA third patient?
Yes, absolutely, provided the chronic disease is stable and optimally controlled preoperatively and the surgical trauma is low.
Is voiding mandatory before discharge?
No. It is no longer considered an essential routine prerequisite for all patients. Planned management should be in place for delayed voiding.
Give me the rapid revision summary checklist, the 4 conceptual pillars that guide every decision in this field.
Okay. Patient selection. ASA, II2, or stable 3. Mandatory responsible escort and adequate social support. Procedure selection. Minimal surgical trauma. Minimal expected blood loss. No specialized complex post-op care. Anesthesia technique. Short-acting agents only. Mandatory multimodal approach with critical PONV prophylaxis and opioid minimization, and recovery and discharge. Meet objective scoring criteria and provide mandatory written instructions and a 24-hour contact number.
That was an incredibly detailed and clinically targeted deep dive into daycare anesthesia. The reality is that the safety of the entire system just hinges on the rigorous application of these protocols, from drug choice all the way to discharge criteria.
The core takeaway is meticulous precision, from the assessment room to the car ride home. Ambulatory surgery is exceptionally safe. The rates of major morbidity are extremely low, but that safety is entirely dependent on disciplined patient selection and an anesthetic technique that is strictly focused on a rapid, comfortable emergence.
You consistently tied successful outcomes not just to physiological scores, but to patient satisfaction and the human experience, noting that staff communication and friendliness are key determinants of overall quality. That suggests a gap between our scientific checklists and the reality of the patient's recovery.
It does. We are exceptional at measuring heart rate, oxygen saturation, and pain scores. But if the human element communication, reassurance, empathy is a top determinant of overall quality, the provocative thought I'll leave you with is this. How can our institutional safety and audit metrics evolve to prioritize and objectively measure the quality of that human interaction in our checklists? Beyond merely checking the box for blood pressure stability, how do we ensure the processes we implement maximize the psychological quality of recovery, which is essential for a truly safe discharge?
A profound challenge to end on. It reminds us that recovery is both physiological and psychological, and the best anesthetic involves a great deal of human care. Thank you for guiding us through these high-yield concepts.
It was my pleasure. Review that conceptual summary checklist and integrate these principles. Safe practice starts now.
We've distilled the key takeaways from this critical area of practice, helping you integrate this information for both clinical safety and examination success. We'll catch you next time for another deep dive.